Yeah.
Buenas tardes, mi nombre es Deyanira Capi Casillas, presidente del capítulo médico estudiantil de la Escuela Nacional de Medicina y Homeopatía del Instituto Politécnico Nacional, de la Asociación Americana de Neurocirujanos, y en conjunto con el Dr. Salim Abdul-Rauf, presidente Walter E. Dandy Neurosurgical Society, al Dr. Babak Katef, presidente de Society for Brain Mapping and Therapeutics and Brain Mapping Foundation, todos presidentes del World Congress UNESCO, ESP-NET and Walter E. Dandy Neurosurgical Society, así como al Dr. Parmenides Guadarrama Ortiz, director del Centro Especializado en Neurocirugía y Neurociencias México, y en nombre del Dr. Jorge Herrera Ramos, señor embajador de la UNESCO y presidente del World Congress, quiero introducir al último ponente de nuestro último día, el Dr. Mohamed Arnaout. Please, Dr. Natalia.
Yes, thank you, Dr. Deya, for the great introduction. My name is Natalia Fedorchenko, and I'm representing the organizing committee of the World Congress of Neuroscience, the World of Neurosurgery in your fingertips. We are happy to see you all today, and thank you for joining us again, because we just had the actually final lecture with the old speakers, but we are really happy that we have one more speaker today from the Egypt. And first of all, I would like to say many thanks to the organizing committee, to the chairman of the Congress, to the ambassador of UNESCO, Mr. Jorge Herrera, for the organizing, for gathering all of us together, to the vice chairmen of the Congress, and for the cooperation with us, the Walter Dandy Neurosurgical Society and Dr. Salim Abdul-Rauf, Foundation for Brain Mapping, and Dr. Babak Kateb for the WANS Medical Students Chapter in Mexico. We have today Deya and Andrea, and a lot of people behind this. We are really thank you, and it's great that we having you, because without you, people will not see us at Neurosurgical TV. So today's our speaker. He will close this session, the first week session, is Dr. Mohamed Arnaout from Egypt. He will introduce himself by himself. He has a lot to say to you. So I would like to Dr. Mohamed say a few words and continue the speech.
Thank you for your nice introduction, and this is a very nice Congress. I have a lot to say. Congratulations to organizing committee for gathering all these speakers from all over the world in the same time, in the same place through this webinar. First of all, I have to introduce myself. My name is Dr. Mohamed Arnaout. I am a lecturer of neurosurgery in a university hospital in Egypt called Zagzag University, very close to Cairo. I'm working as a consultant neurosurgeon. My special interest is in endoscopic skull-based surgeries. For that, I had some fellowship in Italy, in Bellaria Ospedali, with Dr. Giorgio Frank, Dr. Diego Mazzidenta, Ernesto Pasquini, and also in United States in Pittsburgh group. And a few years ago, I went to New York, Cornell, with Dr. Schwartz for more intense education and to learn the skull-based surgeries. And I have did some good publication with him. And for my presentation, can you allow me to start screen sharing?
Yes, doctor, you're allowed to share your screen, right?
It is working now?
Yes, doctor, we can see your screen.
Okay, perfect. So neurosurgical approach for acromegaly or neurosurgical management of acromegaly. First of all, the introduction. The introduction for the pituitary gland and the pituitary tumors. So we all know that the pituitary gland is very important as a maestro of all endocrine glands in the body, and its location in the sella and sella turcica, with a crucial landmark and crossroad for many important structures Anatomically, you know all the optic chiasm above and the third ventricle. From both sides, you can see the cavernous sinus, including the carotid artery and the cranial nerves. And from below the sphenoid sinus, cranial nerves, including third nerve and fourth nerve, and the ophthalmic and the maxillary division of the fifth nerve, and the sixth nerve as well. And from the lateral view, you can see the pituitary can be classified into anterior and posterior pituitary with the optic chiasma just above. Um, the growth hormone secreting adenomas can be dealt with as a special entity because there is no current treatment of complete efficacy to treat these lesions. And although the surgery is the most often the first line of treatment in most patients, but the surgical removal of tumor usually or mostly can not achieve the complete cure because there is a persistent disease in 6,800% of patients after surgery. And so we have to think about the post-operative care for those patients with acromegaly. Is it a medical treatment or a radiation treatment? Medical treatment may be single treatment or a combination therapy, and single treatment in the form of somatostatin analog or the monotherapy or growth hormone antagonist or dopamine agonist in a combination with the somatostatin. Radiation treatment for a persistent growth hormone secreting adenomas after surgery, mainly in the form of a traditional radiation or a gamma knife. So this is the newest consensus for recommendation in 2018 for those patients to be treated in a pituitary tumor center of excellence, and surgical resection should be done by an experienced skull-based neurosurgeon whenever possible, and medical treatment should be reserved to those with a persistent disease or with not candidate for surgery because of high risk, and this medical treatment is the first generation long-acting somatostatin receptor ligand. And if there is a clinical residual tumor, you can start with a long-acting release somatostatin or other drugs. Usually, we refer those patients for our endocrinologist. Another possibility is the radiation therapy in the form of gamma knife. So if we have a lesion in the sella turcica, whether it is a growth hormone secreting adenoma or other pituitary tumor, you think about reaching this tumor from above by using the microscope, transcranial approaches, or reaching this by the endoscope through the endonasal approach. So we have to study this area of the sella turcica and the pituitary gland to know what is the best approach for our lesion, for our patients. So if we have a paracellular extension in this area, there is a very really complex because there is a cavernous sinus, internal carotid artery, and the other structures. Cellular region is an anatomically complex area in the middle cranial fossa with a very important adjacent structures. So our objectives in treatment of acromegaly patient is a control of the symptom and signs and to suppress the growth hormone. And there is insulin growth factor 1, which is analog for growth hormone. Sometimes in some patients we find the growth hormone is normal while insulin growth factor 1 is high. So those patients diagnosed as an acromegaly. The morbidity and the mortality for those patients is very high because the growth hormone is considered a lethal hormone. Lethal hormone, it can cause a cardiomyopathy. There is some reports show that there's increased risk of cancer colon with the growth hormone and also with other morbidities like hypertension and diabetes mellitus and soft tissue swelling all over the body. So I consider the growth hormone is a lethal hormone. So from the objectives of our objective for this lethal hormone to control, to, even to decrease the pituitary tumor size by surgery. If you are not able to make a complete biochemical cure, you have to debulk tumor to decrease the size. Also control tumor mass effect mainly on the optic apparatus, also to preserve the other normal pituitary hormones by preserving the pituitary stalk. Surgical outcome in the acromegaly dependent on the experience of the surgeon, neurosurgeon or scalpel surgeon, and the preoperative adenoma size, invasiveness to the adjacent structures, and also preoperative growth hormone level. We can use this approach with the familiar approach, a pterional approach, for those patients, especially with a paracellular extension. And if you don't have a knowledge for endoscopic endonasal approach, you can use a pterional approach with a very classic approach for a neurosurgeon. But remember, if you use a pterional approach, you have to work through between the two optic, interoptic approach or optico-carotid approach or lateral to the carotid or through the lamina terminalis if there is a tumor extending to the lateral, the third ventricle. Another option is a subfrontal approach, but I don't like it for the pituitary adenomas because it is very massive approach for a midline lesion. Recently, there is endoscope-assisted supraorbital keyhole approach. Minimal invasive technique can access this area for sellar or paracerebral region, and the size of craniotomy is very small, so this is called minimal invasive. There is a small dural opening, less brain retraction exposure, but you need experience. You need uh, to know how to do this approach, and from a small area. You can use a microscope plus endoscope through this small hole to go to the sellar or paracellular region. So in the past 20 years or more than 20 years, endoscopic endonasal approach is gained favor for a primary approach for many sellar, also some sobra or paracellular extension because of panoramic view, close-up view, visualization offered by this endoscope. So we now have the term called extended endoscopic approaches, which now you can enlarge your root and go superiorly or posteriorly or laterally, as demonstrated here. So for a lesion in the sellar or sobra or paracellar, you can reach it from above by microscope or endoscope, or you can use it from endonasal approach. If we shift to the other part of the presentation of the evolution of pituitary endosurgery, first, the first in the history to use this approach, the endonasal approach, was fortunately the ancient Egyptians, the pharaohs. It is about more than 5,000 years ago. This is the history. The ancient Egyptian used to make what is called the mummification process for the body. So they noted that the body organ should be removed from the thorax and the abdomen to allow the mummified body to go for a long time. So, considering the brain of paramount importance and the purpose of not disfiguring the face, keeping the face, so they used it to extract the brain as a liquid from a breach in the sphenoesmoidal area. So then the brain is completely extracted from the nose. So the mummification process not disfigure the face and keeping the face features not for a long time. These drawings showing the route or approaches for the pituitary fossa, either frontal by cross or superior nasal or inferior nasal or transpalatal, sometime fronto-orbital or lateral subtemporal or transesmoidal. The first historical perspective for transsphenoidal approach was by Hermann Schlosser in 1907, performing the first pituitary surgery via lateral rhinotomy. The scan incision was like this to approach the cell. Hirsch used a submucosal resection of septum with an intranasal approach. It is close to sublabial. But in 1910, the Janji-Pakal sulcus used for incision to sublabial and use a sublabial transseptal corridor to access pituitary gland. This approach later popularized by Cushing. This is a sublabial approach. Sublabial approach is a sublabial transseptal transsphenoidal approach. During this stage, this approach was good because of adequate light. Can be you can use a headlight for that. The transseptal transnasal transsphenoidal approach also can be used with less morbidity but narrower corridor for illumination and visualization. Herbie Cushing developed the transsphenoidal technique, which was largely abandoned until 1960 when Hardy popularized the use of operating microscope in transsphenoidal surgery. Since that time, microscopic transsphenoidal surgery became the gold standard for pituitary tumor removal. You can use a fluoroscopy here like this to make sure of your root, and endoscope was first introduced to the transsphenoidal surgery in 1960 by Gerard Joy. In addition to intraoperative fluoroscopy can be used during the transseptal approach, either translabial or via open rhinoplasty, which was and remains a preferred approach in many centers. In 1970, developed more development of endoscope, and in 1992, Jankowski et al. Performed the endoscopic transnasal transsphenoidal approach by using the microscope and endoscope, term called endoscope assisted. In 1996, Joe Carrao described the first clinical series of purely endoscopic pituitary surgery. At that time, the Pittsburgh group, Carrao and Joe, and at the same time in Italy, in Napoli, Dr. Capabianca, Paolo Capabianca, and in Bologna, Dr. Giorgio Frank and Pasquini started the same approach by late 19th. Why endoscopy for this approach? Because the endoscope can give a panoramic view, close-up vision. You are very close to your lesion, wide-angle view, and you have a different angled endoscope like 0, 30, and 45. Depth of field appreciation can be accepted by experience. You can appreciate the depth, although it is 2D, not 3D like a microscope, but with experience you can appreciate the depth of your tools. This is classification for sphenoid a sinus, cellar, precellar, or conical. Conical was considered the contraindication for endonasal approach, but nowadays with the use of high-speed drill, especially for endonasal approach, you can access the conical sphenoidal sinus. Important surface landmarks is very important because the endoscopic anatomy is different from the microscopic anatomy. You have to know where is the sella turcica, where is the clivus, where is the planum, and the carotid artery. Here, this is the midline here, and this is the sella. You can go outside the sella for extended endonasal approaches for paraclinoid internal corridor artery, optic canal with lateral opticura, carotid recess, and lamina papricia. You can access the orbit, and this is the planum, and the clivus is here. So more and more advancement. Diagnostic workup for a pituitary or a cellular lesion should be the imaging better and preferably to be MRI with 3 Tesla, hormonal profile, and other visual assessment. Cavernous sinus invasion can be assessed by what is called Knospik classification, which is introduced in 1993. He described 25 adenomas at the junction of grade 2 to grade 3 invasion, which are here for a cavernous sinus. So the question is it possible to access the cavernous sinus by endonasal approach, not transcranial approach? The answer is yes. And the conclusion of this paper is this approach is being reserved for those with experience, for skull-based surgeon, a neurosurgeon with an ENT surgeon, like a teamwork. The very important tools for these approaches is the navigation. Neural navigation, if you can see, this is an example. You can see here we are here with our tool. You don't know where are you because of the septation in the sphenoid sinus. Actually, this is going to the carotid artery, not to the midline. If you are confusing or you didn't study your patient well, you can see the intrasphenoidal sinus as a midline and go to injure the carotid artery. So the navigation is very important in these events. Intraoperative Doppler is very important to identify the blood supply of nasoseptal flap. Also, identification of the internal carotid artery during surgery. So this is picture from my fellowship in Bellaria Hospital in Bologna, Italy, during the preparation of the patient with neurophysiological monitoring. This is usually for typical for extended approaches. You can see the waves of neurophysiological monitoring. The equipment for the operating room should be in a center of excellence, should be prepared well with monitors like this, one for surgeon, one for assistant, and one for the nurse, one for the anesthesiologist. The instrumentation is very important. All instrumentations for sinonasal surgery plus those for the endoscopic endonasal 3D endoscope can be used also. Training is very important. There is a neurosimulation devices like this one can be used by resident or the young generation to learn how to perform a surgery. You can for devices like this, you can introduce, you can put the images of the patient, you can put the tumor like this, and then to study the tumor, how to approach, and you can use this. Cadaveric labs are very important for training to know how to go through these approaches and to avoid complications. So, how to do this approach? You have to start with appropriate knowledge and skills, knowledge of the approach, knowledge of the complication, and so on. Also, case selection is very important to select your patient with the best approach, danger identification like CCFLIC and so on, planning, and you have an alternative planning in case of complications. So a tumor like this patient has acromegaly with a cellular and supracellular extension adenoma. This is a preparation of the patient. You have to prepare for a fascia, lata here, or a fatty graft when needed. This is the approach. Start by lateralization of the middle turbinate. When you lateralize the middle turbinate, you can find the sphenoid ostium. Sphenoid ostium is about 1.5 centimeters from the choana, and the approach started. This is the typical endonasal approach by widening of the sphenoid ostium and to go to the contralateral ostium. This is the nasal septum here, this is the midline, and this is the middle turbinate. We make like a bridge to go to the contralateral side of sphenoid sinus and the contralateral side of sphenoid ostium. This is the sphenoid rostrum. We remove the sphenoid rostrum by using drill. High-speed drill is very important, and this is the cellular pulse. Here, after removing the septum, you can see and appreciate the cellular pulse. So anatomy is anatomy. The anatomy is very important to know and study the endoscopic anatomy because it is very, this is the bone opening over the sella turcica. You can see this is the dura under the bone of the sella. We extend the bone opening till here. This is the opticocarotid recess, and the opticocarotid recess of the contralateral side is not seen here. opening dura, usually in the crochet manner. Some others use the U-shaped incision, but this one is good. And this is the pituitary adenoma. Tumor start to go. We start debulking tumor. Very important trick to start with 8 o'clock, 9 o'clock, and 3 o'clock, and 6 o'clock. And last one should be the suprasellar part to avoid the premature bulge of the diaphragma. If the diaphragma comes down, you may have a risk of excessive leak, and you can see this is the last part to be attacked, the suprasellar part. The last part to be attacked, the suprasellar part. So we start by here, the sides at 9, 3, and 6, and the last one at 12. This is the last step of the surgery. We use this piece goes to remove any remnant of tumor. So this is this diaphragma celli. This is packing of the cella with a gel foam. And after putting gel foams, so as long as there is no CC flick evident here, we just put the gel foam, and medialization of the middle turbinate is enough. So before you open, you should know how to close. So this is graded repair clinical based effects according to Professor Daniel Kelly from California. He made a grading system for a CSF leak from grade 0 to 3, and according to the leak you use whatever repair you want, using a Valsalva maneuver to confirm a CSF leak or other methods. You may use a natural materials like a fat graft or a fasciolata. You may use artificial like the collagen sponge or titanium mesh sometimes can be used for repair. Gasket seal is one of the repair methods using a fat and fasciolata. There is this paper has made a comparison between endoscopic, endonasal, and transseptal approach, and the results were similar except for some nasal complication with more with a transseptal approach. So this means the endoscopic, endoscopic, endonasal is more recommended. This is an example of a patient of mine. This is a preoperative image, and this is the post image after the removal of tumor. This was a growth hormone secreting adenoma. Another tumor, which is a huge one with a suprasellar extension, and this is usually the follow-up MRI after 3 months of surgery. Some prefer day 1 or day 2. This is a description of the approach. You have to prepare for fasciolata graft before surgery, and the medialization, lateralization of the middle turbinate, and this is the nasal septum, this is tuberculum celli, and this is the cella and the dural incision. And after that, you start with this tumor. Actually, this one was a meningioma. This is optic chiasmal ecam complex optic nerve, and this is a fasciolata graft and overlay fasciolata graft. So if we speak about evolution of pituitary surgery or endosurgery using the scope, we have to know that there is a variety of endoscopic approach have been evolved during the last few years or few decades, including sagittal plan approaches, starting from transfrontal or transcribriform, transethmoidal, transtuberculum, transplanum, and transphenoidal, here transclival approach and transodontoid approach. This illustration from publication by Dr. Kassem, and he illustrates that you can use the endoscope transnasal to approach skull base from anterior to posterior, from lateral to medial. So he classified the expanded endonasal approaches to anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. For the midline, starting from transethmoidal transethmoidal and transcribiform, transplantar tuberculum, transcellular, transclival, and transodontoid approach. For the lateral approaches or the median plane, anterior cranial fossa and middle cranial fossa and coronal plane posterior cranial fossa approaches. This is another illustration of the coronal plane approaches classification. The most important and crucial landmark is the median nerve here. The median nerve is the very important crucial landmark for localization of internal carotid artery at the skull base. And this is the second genome of the carotid artery. So you can access medial to carotid this area, which is called the petrous apex endonasal. This area under the petrous internal carotid artery can be approaches. Also, Meckel's cave, zone 3, zone 4 is the cavernous sinus, and zone 5 is the infratemporal fossa and jugular foramen, and the access to the posterior fossa. So again, you have to know how to close before you open. And this is the level of complexity of these approaches starting from the sinonasal operation, level 1, level 2, the pituitary. You have to perform as many pituitary adenomas as possible. I recommend not less than 30 to 40 endoscopic endonasal approach for adenoma before starting the extradural approaches, like transclival is the first one to be tried. If you have experience and a good ENT colleague, experienced Clival surgeon, you can start transclival followed by transplanum, transcribiform or transplanum transtuberculum. And if you have good knowledge with the extradural approach, start intradural approaches, and after that, the cerebrovascular approaches like some very few neurosurgeons use this approach for clipping of aneurysm, like a basilar aneurysm nasal approach. But so my experience in Zagazig, we worked with ENT colleagues in the last not 3 years, like 5 or 6 years, and we have many adenomas like this with complete removal, and like this, and this is approach. So preoperative protocol for those patients is a CT scan should be a narrow cut CT scan over this sphenoid sinus, and MRI and endocrinological assessment for hypo or hyperfunction, and ophthalmological examination and cerebral angio in selected cases like a cavernous sinus or Meckel's cave tumor. You can try occlusion tests for possible arterial occlusion in case of vascular injury during surgery. So anesthetic considerations, the anesthesia should be providing a bloodless surgical field with a hypotension technique, and invasive blood pressure monitoring is recommended. Instrumentation and operative room organization, as you have seen in the previous slides, there is many systems all over the world, and the most accepted those instrumentation described by Joe and Carl in 1997. There is some by Capabianca and other skull-based surgeons all over the world. The standard is 0 and 30-degree endoscope. You may rarely use this 45 degrees. The standard is 4 millimeter diameter rigid endoscope. Sometimes some surgeons prefer the short one, 18 centimeters endoscope for nasal steps. Some prefer 30 centimeters endoscope, which is called orthopedic endoscope for these tumors. For pediatric patients, small endoscopes, 2.7 millimeter in diameter, and the endoscope column in composed of a high definition camera and the light, xenon light. Some systems has advantage of automated irrigation system to clean the endoscopic lens. and high-speed drill and Doppler and neuronavigation, especially for a recurrent tumor or extended approaches to remove intradural tumor. This is the endoscopic set of monitor, camera, and light source. So if we move to the extended endonasal approaches as a part of evolution of pituitary endosurgery, the transcribriform approach defined by removal of cribriform blade to approaches the anterior skull base. And this approach extends anteriorly from posterior sigmoidal arteries to the cristagal and the frontal sinus. A limit is the lamina papricia laterally, frontal sinus anteriorly, and the transition of the lamina of the planum sphenoidale posteriorly to at the level of posterior sigmoidal arteries. So the cribriform lesions, including meningioma, factor of meningioma, tissue neuroblastoma, and other carcinomas. The advantage improved cosmetics because there is no scar, no wound, reduced brain manipulation because you access the tumor from down, and lower morbidity and shorter surgical time, quicker with experience, shorter surgical time and quicker recovery, short hospital stay. Another approach we can explain is the transplanum transtuberculum approach. This is described for tuberculum meningiomas. Transplanum approach, it is a removal of planum sphenoidalis bone and tuberculum celli by using high-speed drill and is limited laterally by the optic canals, anteriorly by the posterior sigmoidal arteries. The critical anatomical landmark is the medial opticocarotid recess. Important bilateral related structures should not be injured, and keep in mind to preserve optic nerve, carotid artery, and anterior cerebral arteries. The indications for using transplanum transtuberculum approach lesion involving the posterior aspect of anterior skull base and the supracellular region, mainly the tuberculum meningomas or meningioma of planum sphenoidale. Also, a giant pituitary adenomas with a supracellular extension cannot be approached by the classic transphenodal approach. You have removed more bone through the planum and tuberculum. Also, a cranioformus largest cyst above the cella and the epidermoid and radic cleft cyst. This is a direct route to the midline lesion with a suspension and play. We don't touch the critical neurovascular structures because there is we don't place the neurovascular structure between the tumor and the surgeon eye, which obviates the need for brain retraction. Also facilitate complete and bilateral optic canal decompression without manipulation of the compressed optic nerve from below, and enable surgeon to remove a bone from the base of the tumor site for meningioma. So this can decrease recurrence. You can achieve symptom grade 0 and allow surgeon to interrupt the blood supply as early in the operation. This is the description of the supradiaphragmatic approach. You can see here, this is the lesion, this is the cella, and the lesion is above. So you have to access through the tuberculum and the planum. So this is the classic transcellular approach. This is a part of bone to be removed in this area, the tuberculum and the planum. And so you can see, if you remove this bone, how you can see supracellular cistern very clearly. And this is the pituitary gland, this is the stalk. So it is this approach is designed for the supracellular extension mainly. So after removal of tumor, you can see the ACAM complex very clearly and the optic nerves. The selection criteria for this approach, as an example of endonasal extended approaches, you have to select a patient with tumor like this with no internal carotid artery encasement or optic nerve encasement. So lesion strictly in the midline like this. And you can see here the arteries, the anterior cerebral arteries above the tumor. When you go from down, you can access the tumor and facing this A1, A2 complex after removing the tumor. So the advantage of this approach, you can achieve Simpson grade 1 resection because you remove the bone and the dura from this area, so there is no risk of recurrence of the meningioma. Also, the early devascularization of tumor is one of the principal for meningioma surgeries, and this devascularization because these tumors take blood supply from the base, the dural tail from the base. You remove this dural tail. Extra-arachnoidal dissection because you access the tumor from below and reduce risk to injure the feeders for chiasma or superior meningohypophyseal trunk because you can see it clearly. So the mobilization of optic nerve after tumor removal is possible, but I don't recommend it. And when it is not hooked by the tumor, this is the optic nerve, and this is internal carotid artery and ophthalmic artery. So this is your access from here. The limits for this approach, you have to know how to close because there is a high risk of CC leak and also endoscopic train surgery and strict midline lesion extra arachnoidal meningioma. So this approach allows access to the infromedial portion of the optic nerve, which is blind for the transcranial approach. This area is blind from above for transcranial approaches. You see here this area, and this is a meningioma. Is here from conception. If you act from transcranial, there is a blind. This area is blind below the optic nerve. We can move to another approach, transclival approach. Clival is can be easily approached transsphenoidally because there is a narrow field of view by the microscope, so you can use the endoscope. A transclival approach can be used for clival lesion as clivals extended from the dorsum celli to the foramen magnum, and the transclival approach divided into partially a superior transclival and the middle transclival and inferior transclival or a complete clival removal. This approach provides direct access to the brainstem and the vertebral-basilar arterial system. As I said before, some surgeons use this approach for cleaving of a basilar tibia aneurysm. Transclival approach, clival lesion can be mostly the most common is scardoma and followed by a chondrosarcomas. Also a meningioma or a cholesteatogranuloma or epidermoid or mucocele or aneurysm, it is rarely. If the aneurysm has a significant mass effect, can be accessed by this approach and can be clipped. Transclival approach avoid any brain retraction and decrease incidence of injury to the lower cranial nerves because it is a direct, strict midline approach. The contraindication for transclival approach patient with a comorbidity which may preclude a prolonged general anesthesia and unfavorable anatomy like small sphenoid sinus or diminished space between internal carotid arteries, which called kissing carotids, making drilling clival bone more risky and difficult, lack of multidisciplinary team cooperation and experience, and lack of specialized equipment and instrumentations. Very important trick for this approach is Cassam line. Cassam line from the anterior nasal spine to the this is the hard palate. You can draw this line. If your lesion is above this line, so you can access it through the intranasal approach. If your lesion below this line, you cannot access through the transclival approach. This is an example of transclavian approach. Patient 54 years old, female patient operated in my department, operated by me, neurologically free, except from 6 nerve pulsation with a retroclival lesion. This is a lesion, and we operate by trans. This is immediate post-op CT scan demonstrating how we drill the bone to access this lesion. This is the intraoperative image of a dorsum salis sphenoid and the clivus, and you work only through the clivus. This is the another patient of chordoma. This is the lesion, retroclival lesion, and a postoperative MRI. There is complete excision of the lesion. This lesion is very difficult through the transclavian approach because of the comorbidity and the mortality. And fortunately, this patient was completely extradural. So this is the lesion. You can see this is the clivus, and after removal of the tumor, which was completely extradural, we use a fascial data and the surgical angial foam, and this is the nasociptal flap. Transodontoid approach is possible also using this endonasal, mainly for degenerative and inflammatory diseases, and to allow exposure of the ventral medulla and upper cervical spinal cord, usually used for a foramen magnum meningiomas, also to decompress a brainstem in rheumatoid arthritis or in case of basilar invagination, and can be used for transnasal odontoidectomy. This approach can be used also to access tumors located within the. Another approach is transorbital approach, which is used for accessing tumor within the orbit, maybe extraconal or intraconal. The indications are resection of sinonasal lesions invading the middle wall of the orbit as a sinonasal malignancies with extension into the orbit, also to decompress the optic nerves in the presence of unresectable intraconal pathologies. To access intraconal diseases, the goal of resection with the goal of resection for schwannomas or cavernoma and also in meningiomas. So, to save time, we move to a conclusion. The conclusion is the collaboration with the ENT skull surgeon and with the technology advances in the field of endoscopy and the instrumentation with knowledge of comprehension of the skull-based endoscopic anatomy, as seen from below, and with the recent innovation in the reconstruction technique, there is improvement in the management of cranial base lesions. The extended endoscopic skull-based surgeries becoming the gold standard approach to the cellular and retrocellular and the clival region. However, its role in the management of anterior skull-based tumors still debated. So, after this presentation, what is your approach for invasive pituitary adenoma like this? Can I hear from you? Are you here?
Yes, yes, we are here. So you finished. I thought you wanted to say something about this picture. Yes, thank you for the presentation.
No.
We have one question for you.
I am asking about this lesion. This is pituitary adenoma, very invasive. What is your recommendation for the approach? Is it endoscopic endonasal or transcranial?
I think maybe taking into account the size of the adenoma, endoscopic might be not really suitable, but I might be mistaken because taking into account the location of it, like it is more comfortable to go through the nose to get it, but it is really big. So maybe you need to do the approach like transcranial.
Yes, you are right. And this patient was approached by the transcranial approach. So my message is adapt your knowledge to your patient, not the patient to your knowledge. I mean, not every pituitary adenoma to be approached by the endonasal approach. You have to learn both transcranial and the endonasal approach and adapt the approach to the patient. And this is the most important message to be delivered. And also the learning curve for endoscopy, neuroendoscopy is very still long, more than the microsurgery, and this needs some money and efforts. Thank you.
Yeah, thank you too. There is one question to you from our auditorium. Like, taking into account the current pandemic, does it really increase the risk of contagions for neurosurgical personnel who perform transcranial endoscopy neurosurgery?
Okay, so there is a case report published in Neurosurgery in January 2020 of a patient who has a pituitary adenoma in China. And after surgery, they discovered the patient has a COVID, and some of the surgical staffs has the COVID, and unfortunately, this patient passed away. And after that, all neurosurgical societies recommended to try to not to delay, but to shift from the endonasal approach or keep the endonasal approach only for emergency cases to limit the possible transmission of the COVID, because you know all this virus is highly virulent in the mucosa of the nasopharynx. And these precautions were to limit the endonasal approach for emergency cases, and to not to use drills, and use precautions of face mask and the N20, the N95 masks, and to use the negative suction operating rooms, and to limit the drilling and the shaver, and so on. All these precautions are written well. But in my experience, I didn't find any patient during this year with the possibility to transmit COVID. In my personal experience, I performed for the patient preoperatively a CT chest, and we ask if there is a suspicion clinically, there is COVID-related symptoms or exposure to any COVID uh, patient. I ask the patient to do the nasopharyngeal
Pharyngeal
swab.
scan.
Yes,
Mhm.
and after that. We operate the patient without problem, and all patient during this year, I didn't face any COVID infection. For my point of view, I have a recent publication of that, like a protocol or a protocol for those patients. In my, I can forward this publication for you. It was in Surgical Neurology International by
Mhm.
my name, and we have a protocol for those patients.
Yeah, it really makes sense because, like, if the doctor got sick, so who will treat all those patients who require the emergency, especially?
All
So,
right.
thank you, Dr. Mohamed Arnaout, for the interesting lecture, for the closing this cycle of lectures for this week for our Congress. It is great to have you with us. Really, thank you for the lecture. Thank you for your time, and we hope to see you in the future.
Yes, of course. It will be my pleasure to see you, and thank you for you and for introducing me, and for all the organizing committee and this outstanding presentations and webinar, and wish to join you later in many meetings. Fortunately, to be actual meeting, not virtually like this after the COVID has gone.
Yeah, it will be great. So thank you very much. Dr. Deya, would you like to say some words?
Oh, thank you, Doctor. It was a pleasure for all of us to have with us today.
Thank you for your
Yeah.
nice words.